Students, we will start with the dopamine and acetylcholine imbalance in the striatum. Then classify Parkinsonism, and finally build the drug treatment strategy around levodopa, enzyme inhibitors, dopamine agonists, amantadine, and anticholinergics. Keep one big idea in mind throughout the lesson. Symptoms appear when dopaminergic activity falls and cholinergic influence becomes relatively dominant. Normally, movement is coordinated by a functional balance inside the extrapyramidal system, especially the striatum. Dopamine acting mainly through D1 and D2 related pathways provides an overall modulatory, inhibitory influence, while acetylcholine contributes excitatory influence. In Parkinsonism, degeneration of dopaminergic neurons reduces dopamine tone. The result is an imbalance. Too little dopamine and relatively too much cholinergic activity. This explains why two opposite therapeutic strategies can both help either increase dopaminergic effect or decrease central cholinergic effect. Parkinsonism can be broadly divided into primary, also called idiopathic, and secondary or drug-induced forms. In primary Parkinsonism, the exact cause is not fully known, but progressive degeneration of nigrostriatal dopaminergic neurons occurs, and oxidative stress from dopamine metabolism has been implicated. In secondary Parkinsonism, dopamine neurons may not be destroyed. Instead, drugs such as antipsychotics block dopamine receptors, especially D2 receptors, and produce Parkinsonian symptoms. This distinction matters because drug-induced cases often improve when the offending medicine is reduced or stopped. Levodopa is the most important anti-Parkinsonian drug because dopamine itself does not cross the blood-brain barrier, but levodopa, its metabolic precursor, does. After oral administration, levodopa enters the brain and is converted to dopamine, helping restore motor control. That is why it improves bradykinesia and rigidity most dramatically. And it can also help tremor, facial expression, speech, drooling, and overall functional performance. Clinically, levodopa remains the gold standard symptomatic therapy for many patients with Parkinson's disease. A major problem is that a large part of levodopa is converted to dopamine in the periphery before it ever reaches the brain. Peripheral dopamine contributes to adverse effects such as nausea, vomiting, and cardiovascular changes. This is why levodopa is usually combined with a peripheral dopa decarboxylase inhibitor such as carbidopa or benserazide. These drugs do not significantly cross the blood-brain barrier. They block peripheral conversion, increase the fraction of levodopa reaching the brain, prolong its action, and allow the levodopa dose to be reduced substantially. Even after peripheral decarboxylase is blocked, levodopa can still be metabolized by catechol-O-methyltransferase, or COMT, into 3-O-methyldopa. That reduces the effective amount available to the brain. COMT inhibitors solve this problem. Entacapone acts mainly peripherally, while tolsapone acts both peripherally and centrally. Although tolsapone is limited by hepatotoxicity concerns. By inhibiting COMT, these agents prolong levodopa's half-life, increase brain availability, and help smooth out wearing off fluctuations in advanced disease. Another central strategy is to prevent dopamine breakdown inside the brain. Monoamine oxidase type B, or MAOB, is an important enzyme for central dopamine metabolism. Drugs such as selegiline and rasagiline inhibit MAOB and therefore prolong dopamine action. Beyond enzyme inhibitors, dopamine agonists like pramipso, ropinirole, bromocriptine, and pergolide directly stimulate dopamine receptors. Amantadine is different again. It facilitates dopaminergic transmission and can be especially useful as an add-on drug, including in some patients with dyskinesia. The second major treatment principle is to reduce central cholinergic overactivity. Anticholinergic drugs such as triaxiphenidal, also called benjexol, procyclidine, and bipridine can help tremor and rigidity, and they are particularly useful in drug-induced Parkinsonism caused by antipsychotics. However, they are less effective for bradykinesia and should be used carefully, especially in older adults, because anticholinergic adverse effects include dry mouth, blurred vision, constipation, urinary retention, and confusion. Levodopa is highly effective, but it also has important precautions. Common adverse effects include nausea, vomiting, postural hypotension, involuntary movements or dyskinesias, and psychiatric symptoms such as confusion or hallucinations. Protein-rich meals may reduce absorption. Pyridoxine can increase peripheral metabolism of levodopa when it is given without carbidopa. Antipsychotic drugs can antagonize its benefit by blocking dopamine receptors. It should be used cautiously or avoided in patients with psychosis, certain cardiac arrhythmias, angle closure glaucoma, or melanoma-related concerns. So the whole chapter can be remembered in one framework. Parkinsonism reflects reduced dopaminergic influence and relative cholinergic excess in the basal ganglia. Primary disease usually involves neuronal degeneration, while drug-induced disease often involves receptor blockade. Treatment therefore follows two paths. Increase dopamine with levodopa, decarboxylase inhibitor combinations, COMT inhibitors, MAOB inhibitors, dopamine agonists, and amantadine, or decrease acetylcholine with centrally acting anticholinergics. If you remember the balance, the drug classes, and the rationale behind combinations, the topic becomes much easier to master.